Good morning, everyone. Thank you, ma'am, and thank you, Dr. Ritesh. Most of the doubts have been cleared by the seniors, and I'll be dealing with toxoplasmosis, ocular toxoplasmosis looking into the fog. So, once we are dealing with the uveitis, there are cells, there is vitritis, the foggy vision of the patient, foggy view of for the doctor, and also the doctor's mind goes foggy because there are so many differential diagnoses. So in this, the presentation will act as a lighthouse in this fog and help you out to get into a clear-cut diagnostic approach and to reach the diagnosis and treat the patient. So there are so many questions coming into the mind. Is it just a spillover in the anterior uveitis? It is a posterior uveitis, pan uveitis. If it is a choroiditis, whether it is disseminated, focal, multifocal, all those doubts and good pictures have been shown by Dr. Tinku. Is it an infective pathology or it is a non-infective? It is an infective pathology. Be careful. Do not start steroids in the same go when the patient is presenting. Investigate the patient. Or is it just a recurrence? What is the state of the patient? Is he immunocompromised? What is the systemic problems going around? Or else it can be a masquerade syndrome. So there is a fog in the brain also now, whether it is retinitis, a chorioretinitis, or a choroiditis. Majorly, as madam has told already, the retinitis, it presents with a severe vision loss, a lot of cells, whitish lesion associated with sheathing of the blood vessels, whereas the choroiditis, it presents as a mild to moderate vision loss, a clearly defined lesion with blurred margins, and it will be a deeper pathology, a yellow looking lesion. And in chorioretinitis, it will be a mixed pathology. All of them can present with papillitis, neuroretinitis, and can present with macular edema. So coming to how the toxoplasmosis, so in the anterior uveitis, it is the mainly we come to get to know the anterior uveitis, that is 47% is anterior uveitis. Out of the posterior uveitis, toxoplasmosis has the highest incidence. This is an Indian study. 40%. So posterior uveitis 29%, out of them 40% is toxoplasma. It can present as congenital or acquired. Congenital mainly comes as systemic toxoplasmosis, so we don't get to see them much. It occurs in the first trimester and mainly leads to abortion. So, and in third trimester, it presents as an ocular, it gets transmitted to the child as an ocular toxoplasmosis, and the percentage is around 60%. So acquired is 35%, which we are dealing with. Ocular toxoplasmosis, it is an obligate intracellular parasite, and the main definitive host is cat. And the transmission occurs with uncooked meat and also with vegetarian diet, which is not washed properly. So the sporozoites are, the three morphological forms are oocyst, which is a dormant phase, and then it comes into tachyzoid stage, and then the tissue cyst, which are found in the intermediate host, which can be a man or a pig. So coming to the symptoms, the blurred vision is the common. The patient comes with a blurred vision, or it can never ever present as blurred vision because if the site is in the nasal area. So the patient can never get to know that he has got toxoplasmosis. If in the center, then the vision losses can be due to because vitritis, dense vitritis, can be because of macular edema, retinal necrosis, CNVM, and the marked vision loss occurs later on once the scar is left behind. So the presentation, it is once you see a dense vitritis, and underlying there is a lesion in the macular area. This is classically described as headlight in the fog. And if it is associated with focal vasculitis, it is called Chiaralis arteriolitis. Punctate outer retinitis, they are the rare presentation, but they don't present with dense vitritis because the lesion is in the outer retina, not towards the inner side. So in other people, it can present, if it is a patient is immunocompetent, it presents as unilateral and with less vision loss. But in neonates and immunocompromised, the lesion is bilateral and presents with severe vision loss. This is a HIV patient with toxoplasmosis. So you can see multiple foci of a thorough ocular examination in any uveitis patient is must, because this will help you in going towards the right diagnosis. The visual acuity, taking the ocular pressure, looking for KPs, looking for cells, looking for synechiae, looking for a complicated cataract, looking for retrolentil cells, vitritis, disc edema, pars planitis, and of course the macular lesion. And in case you are leading with the toxoplasma, then look for healed versus an active. A healed lesion will be having a punched out margins with hyperplasia of RPE, and in an active lesion, you can always see a old scar mark, and adjacent to that, a fresh lesion is occurring. So investigations, after doing a thorough 90-day examination and a indirect ophthalmoscopy, just angiography or a colored fundus photo is essential to take a serial fundus pictures later on to know that the patient is getting treated. This is the angiography picture, which is showing the toxoplasma lesion with a hemorrhage and a blocked fluorescence in the center with a late stage, and there is a late stage, there is fuzziness around and leakage around the lesion. So the blocked fluorescence here was because of a macular edema, and the vasculitis can also be seen in the periphery. Serological diagnosis remains the mainstay. Though a positive IgG doesn't prove that it is a toxoplasma, the rising titers help us in knowing that we are dealing with toxoplasmosis. But the helpful thing is a negative IgG excludes that it is not ocular toxoplasmosis, so it will help us. IgM is of less value. Sometimes there is only a transient elevation, and PCR is considered to be confirmatory, but it is invasive. So the confusion now gets cleared up once we take a good clinical history, clinical examination, we are investigating, and we are doing a serological diagnosis. But when to treat? The lesion is in the temporal arcade. Whenever there is a vision-threatening lesion, which is causing vascular block or optic nerve head involvement or a dense vitritis, you have to treat it. So treatment options available with a different clinical presentation. This is the case 1. This patient presented with 6/6 vision in right eye, and in periphery we could see the focal lesions and somewhat scarring. So we did an angiography and we found that there was staining mainly and a little bit of leakage in the lesion. The other eye, the vision was dropped to 4/60. There was a dense, there was a central focal lesion with less vitritis. So differential diagnosis could be tuberculosis. But then we did an angiography, and also we waited for the serologic reports to come. So since the serologic came to be positive, the presumptive diagnosis of ocular toxoplasmosis was made. Severe vision loss, focal chorioretinitis, posterior polar lesion, vitritis with minimal anterior uveitis, serologically positive, and the central hypo dye leakage from the margins. There was no old scar, but that is not the essential thing, and there was no history in the past. Treatment was started. This is a standard treatment, tablet trimethoprim and sulfamethoxazole. Then along with that, because the patient had cells in the anterior segment, we started prednisolone and hometropine. 3 days later, we added oral steroids. And after 5 weeks, we could see that the lesion is getting a well-defined margins. The leakage is minimal on the angiography. The vision started improving. The vitritis was minimal. And there was a healed mark on OCT. The signs of healing were there, and there's a ERM here. A second case, the patient presented on first day just with a 2 days history of vision 636. And on doing an angiography and OCT, we just found a focal sign of vasculitis and nothing else. And the lesion was also not very prominent. So we ordered all tests, ESR, CBC, tuberculosis for MON2 and chest X-ray, and also ordered toxoplasmosis, IgG and IgM. And the patient didn't turn up quickly, so we were waiting for the patient, and he came after 1 week. There was dense vitritis this time, mild disc edema, and once we did an angiography again, there was a hypofluorescence in the center with a fuzziness which later on increased, and a serous retinal detachment on OCT. So the vision was now counting finger 1 meter. And IgG was elevated with a mild increase in IgM values. And tuberculosis MON2 came out to be equivocal. So since we thought we are late for the treatment and the vision from 636 is dropped to counting finger, we started the patient on quadruple therapy, steroids, Cyplin DS, that is trimethoprim sulfa, and clindamycin, and waited for 2 weeks. Now the patient is in this stage. We will continue the treatment for 6 weeks total. And the vitritis is still present, but the lesion is now well defined and the macular edema has gone. So early treatment avoids nasty situations. Thank you.